And now this is a patient who present with effort angina, elderly gentleman, and he underwent angiogram. Show the next image. He had a proximal LED tight stenosis. In this particular view, you can see that there is a proximal LED calcified tight stenosis. He also has a diagonal. It's not a huge one, almost 2 millimeter in size. Next image. Next image. So that's again the calcified LED disease, proximal LED disease. Next one. Next image. Next image. That's the right coronary artery. You can again see that there is a tight stenosis in the proximal right coronary artery. It's a calcified lesion. This is what we are planning to have do today. The LED we have already done with orbital atherectomy a couple of weeks ago. It was basically a provisional strategy. It was LED D1 bifurcation, and we just had a wire in the LED, had orbital atherectomy, and had the LED stenting done. That's enough, Jojo. That's enough. We'll continue with the talk here. So this is the first case that we are going to do. It doesn't look like a very challenging lesion in the RCA, a calcified straightforward lesion in the RCA. So we'll start off with this particular case. The creatinine was a bit on the higher side, though, so that was the reason why we had to stage the procedure. So today we'll be having it done with OCT, and saline OCT would probably try to reduce the contrast with saline OCT. That's the plan like for the day. We'll also have, by and large, when you do orbital atherectomy, you don't need a temporary pacemaker lead inside the right ventricle. That's what the routine practice is like. But yesterday when we had a case done for an RCA, we saw AV block during the procedure. We didn't have the temporary pacemaker in, but then it compared to ROTA, what happens is with orbital atherectomy, even when they develop IV block, it immediately resolves. We didn't even have to give atropine. There was significant amount of brady, but then it resolved by itself. So we thought we'll have a temporary we'll have a sheath in the femoral vein, not go with a temporary pacemaker inside. In case a need arises, we'll have the temporary pacemaker put in. So that's the plan like for this particular case. You can just highlight on this case something if you want, and then we'll have your presentation. What would be your approach like? Yeah.
First of all, at the outset, I'm thankful to Dr. Deepak Davidson and Industry Abad for giving this opportunity regarding this presentation as a chronic stable syndromes. And after coming LED, the RCA, you can see so many varieties of calcification. Here it is a classical tram track calcification with a tight stenosis. And here the vessel size is more than 2.5 millimeter and non-tortuous. So this is an ideal case for the beginners for starting the orbital atherectomy. So first of all, here the most challenging cases, as everybody knows, the calcium, the imaging ultimately will be very useful, crossable or uncrossable. If the imaging catheter is crossable, then you can do the OCT image or intravascular imaging and see the patterns of the calcium 360 degrees, and the wall calcium also more than 0.5 millimeters. The quantification is important, so that you should do with more aggressive atherectomy devices. Once the fluoroscopically tram track means, definitely the score will be more than 4, actually the SLOSA scoring system by OCT. So naturally the atherectomy device you have to use and debulk the calcium. Always whenever a fluoroscope visible means it is significant calcium, very important. And if you take the different modalities of imaging, the CT angio will overestimate the calcium, fluoroscopical use will underestimate the calcium. Once fluoroscopically visible means definitely it is a severe calcification, always it indicates. And different patterns of calcification, sometimes pools of just eccentric calcium will be there. Sometimes coronary calculus, like just intraluminal filling defect like thrombus mimicking also we have seen. So it is nothing but a protruding calcific nodule. So usually they will 90% they will present as acute coronary syndromes in elderly people. But here very classical chronic stable syndrome, tram track calcium and all these things, it seems a OCT crossable, it seems like. So quantified more than 4 it will be there, we can see. And then because the stage segment more than 2.5 millimeters is the vessel size and non-tortuous, is an ideal case for the beginners for the orbital atherectomy. We can able to hear.
Yeah,
why we have selected the AL Or
Uh,
AR.
it's a short amplats catheter.
Okay.
Normally in difficult lesions, we always prefer using a short amplats catheter.
Okay.
The advantage is you have good backup support, and it is not as aggressive as the AL1 catheter. So it is less aggressive, but then you have a reasonably good backup support with this catheter. So that's the reason why in calcified lesion, difficult lesions, most of the time we would prefer using a short amplats catheter. We have little bit of damp.
Usually we can take a JR 7 French, which gives good support.
Certainly.
Usually we take for the
here we do have little bit of dampening. Once we have the wire deep inside, we'll get the guide back.
Right.
So here we are using a workhorse wire to wire it. Normally we always, even though it's easy to wire with a wiper wire, we always tried wiring with the help of the microcatheter also, so that once you have the microcatheter, the kinks in the wiper wire could be avoided. So we always try doing this. Now here we do not have the microcatheter over this wire, primarily because we thought that we try doing, it's not a very critical lesion, so we thought we try doing the imaging first. So we go with OCT, and once we do the imaging, then we'll exchange it with a wiper wire. So that's the plan, so that's why we've gone with the wire alone without the microcatheter. Now the pressures are good. We'll go with an OCT catheter. We try to image the coronary artery. Because the creatinine is mildly on the higher side, we'll take a small shoot. We're planning for
saline OCT.
We're planning for saline OCT. Before that, Vishnu, can we have a very small shoot so that we can have a reference with that? Yeah, that's it. Okay, I hope you can see the amount of calcification. It's a significant calcification, tram track calcification, and it's a tight lesion also.
Yes, exactly. Stent-like calcification, tram track.
Now we'll go with the OCT catheter. Can you get us the OCT catheter? Yeah. We have a venous sheath also in situ inside the femoral vein.
Yeah, that's a good strategy because the no flow slope is unpredictable.
Okay, 20 cc syringe. Saline.
I think got some friction at the lesions.
Yeah.
Tight lesions.
But it's gone halfway through, so we try to certainly do an imaging with whatever, at least a partial imaging we'll try to do.
That's a good strategy. So these are the very classical calcific lesions cause problems regarding the catheters, device, and all these. It prevents the crossability of the lesion, even though the luminal lesion was there without haziness.
Image on.
That rough surface will catch hold the image and prevent its advancement.
Image on. Ready? Yes. Yes.
Yes, it's almost 360 degrees calcium, and thickness of the wall calcium is more than 0.5 millimeter. You see how thickness the calcium.
Measure.
Yes.
That's just need the wire. Can you see the? Can you show us the OCT images? Can you give me a 7.5 glove? Okay, so these are okay. I hope you can see the OCT images. I'll just go through the OCT images.
Yeah.
Well, that's the area where the imaging catheter wouldn't cross. Here you could see that it's almost 360-degree arc of calcification over here, almost 360, and you could see that at 6 o'clock position it's more of deep calcification.
Yes.
All the other areas it's more of superficial calcification. Then as we come more proximally, again it's a 360-degree arc of calcification. It's a very thick arc of calcification. At least whatever is reassuring would be probably at this particular area it appears to be thin, so that following the lesion ablation, we hope that we'll be able to dilate it with a balloon and open it up, produce some cracks over there. These areas we are happy because at 1 o'clock to 6 o'clock position, you could see here that it's a thick calcification, but 12 o'clock and 6 o'clock position, you could see that it's not so thick calcification, which would certainly be helpful for us to break that calcification with a balloon. And as we come more proximally, again, so you could see that there is significant amount of calcification, but then you're not seeing any significant nodular protrusion inside the lumen, but then distally inside the lesion, probably you should be having some nodules also over there. So as we come more, as I'm going more distally, so that's the ostium. There we do not have significant amount of calcification. Here you can see that at 12 o'clock position, you can see a nodule over there, but then if you carefully look at the imaging catheter is much away from that particular nodule. And again, that nodule is not an occlusive nodule. It's a very small nodule. So mostly when you do orbital, it's not going to touch this particular area because it's a big vessel proximally, and it may not touch this particular area because the imaging catheter is much away from that particular lesion. And as we go in, again you can see that this is more of again a nodular thing seen at 1 o'clock position, then intimal calcification seen down there. And as we go distally inside the vessel at these areas at 11 o'clock position, you can have the catheter being close to this particular calcium, and it's more of eccentric calcification. This areas you could expect sanding with the orbital atherectomy device. And again till the distal end, you can see that it's a, so we could see 360-degree arc of calcification, deep calcification, superficial calcification. Some nodule is seen which is not of much of significance in this particular situation, and you can also see areas wherein you have thick calcification and you have areas where you have thin calcification also. So we start off with orbital atherectomy now.
Yeah.
Can we have the microcatheter and exchange it for that? Pressures are okay, right?
Yes. 140 is
okay. So we'll have the microcatheter going in, and then we'll exchange with the wiper wire.
You do not want to put TPA lead.
We have the sheath in situ. We'll get ready with the TPA, but then we wouldn't want to have it inside the right ventricle.
Okay. Now the
We are
next
seeing
step
the
what they are
calcium,
doing,
seeing the
exchange
amount of
with the wiper wire. Microcatheter exchange with the wiper wire.
seeing the amount of calcification there. Probably you would want to have the temporary pacemaker inside, right? Because we expect some sort of slow flow during the procedure.
Definitely, as the lesion, calcific lesion length is longer and longer, there may be more chances of no flow or slow flow phenomena, unlike a focal calcific lesions.
As Dr. Vishnu is wiring with the wiper wire, what I'll do is show us the orbital atherectomy device. Can you enlarge the camera and focus onto the table? Enlarge the camera image and focus onto the table. Okay, that's the cam. Okay, now open it up. And we'll take out the microcatheter.
Yeah, classical.
So that show us the pump there. Arya, are you ready with that? Okay, so we have the saline. Show the pump and the saline. Okay, we have this saline with the wiper slide. For 1 liter of saline, you need around 20 ml of wiper slide. Wiper slide is this white milky fluid that you have over there. It makes the thing slimy, more slimy and more
Yes.
slippery, so that slow flow could be reduced. There is no friction between the sleeve and the drive shaft of the crown. So that
Yes.
those are the advantages. So can you connect all
They
these
already
things?
diluted the fluid actually.
Yeah,
if you can
yeah.
carefully see.
That's
And
almost
then the dead button, they have the power check next.
okay. Is the 20 cc or 10 cc inside that wiper slide? 10 cc. 10 cc. Okay, it's a 500 ml saline bottle. So
Yes.
you have around 10 ml of wiper slide inside that.
Yes.
Now we'll go with the device. So
20 ml in 1 liter dilution.
it's again, now can you focus over here? Again, now here it's again something similar to the rota. You just have to put it upside down. Okay, now here we have the wires. That's for the electricity for the motor. Then we have the
Yes.
tubing for the saline.
Yes, so that is a roller pump. You can have to fix the tube. Yes.
Yes.
No.
Yes.
It aerating the bubbles. You can
So
carefully see.
they prime the catheter
Yes.
so that there is no air bubble inside that.
Yes.
Okay, you can show the tubing.
You can see how the bubbles will be removed.
That is just to remove the air bubbles from inside the tubing.
Yes. Then they will close with the knob.
Okay,
That
now
Y
show
connector.
here. Can you focus on to my hand? Okay, so here we have the saline. We do not have to adjust the drip rate like what we do for the rotablation. Here
Yes.
basically you just have one speed and it just comes over like that. That's right? Okay, so that's again it said that every minute around 16 ml it flows through this particular through this catheter, so that it just washes away whatever debris is formed inside the vessel. Now what we do is we get the orbital atherectomy crown till the Y connector, and then we check few parameters. That's what we are going to do. So can you focus on to this particular area? Okay.
It's exchange the wiper wire na already?
Yeah.
Okay,
So
okay.
what we have done is we had the workhorse wire inside the coronary. We took a microcatheter inside. Over the microcatheter, we have exchanged the wiper wire. It's usually not a very cumbersome procedure. It's an easy procedure. Keep the temporary pacemaker also ready. We also keep atropine ready over there. So
Checking
now the parameters whatever we are going to check for is, one, you can see that the drip rate is okay. We look at the pump. Make sure that things are over. The saline bottle is good. The saline whatever is being flushed over here is adequate. It's flowing very well. Then what we do is we look at we just rotate it and see whether it's rotating properly. So for that, can you focus on to this particular area? Okay, so this green light, it's for 80,000 rpm and this is for 120,000 rpm. We just have to check once with 80,000 rpm. So that's what we are going to do, and always keep the knob in the lock position. This is unlock position, like you have the wings looking outwards. It's like the bird about to fly. The wings are wide apart. So this is the lock position, and this is the open position. When you do the burring, you keep the knob in such a way that the wings are in open position. Here you have the wings in the closed position. So now whatever we are going to do is, first thing we are going to activate it, see whether the crown is rotating well. Okay, always make sure that you have the break down. Otherwise you won't be able to switch it off.
Activated.
Now that's how it looks like. Okay, you're seeing the spurting saline and it's rotating well. Now we switch it off. Now again you need to move the knob forward and backward. Show the handle now. Show over here. Okay, now you can also move it forward and backward.
Yes.
Make sure that it's working well. So these are the parameters that probably you need to check before you take the orbital atherectomy catheter inside the coronary artery. We are having reasonably good pressures now. So we keep the advancer knob over here. That's how it's in lock position. Now we get the atherectomy device, the crown inside the coronary artery. Now again, it's a very simple procedure. It's something similar to rota. You can always you can push pull. You can one operator can pull it back, and the other operator can push it forward, the burr forward, or you can do it with one operator also. That too is possible with this. Now we need to unlock it. We need to release the brake so that
Yes,
you are making the wire free.
Yes, correct.
And now can you, okay, we are pushing the crown inside the coronary,
Right.
and then I'm slowly pulling out the
Yes.
wiper wire also.
Yeah.
Two branch now.
Now can you focus on to the, can you make the fluoroscopy larger, enlarge the fluoroscopy screen and make this one smaller, okay, that's fine.
Yes. Yes.
We are not seeing that. We are not seeing the camera image on the monitor. Can you show the camera image also on the monitor?
Yes. Yes.
Okay, so that's what we are doing. Probably the push-pull technique. You pull the wire and push the device forward. There are other ways of doing that also with the help of glide assist mode. Probably in the next case we can see those things also. I think we'll keep the wire there only. We are somewhere near, now we are near the lesion.
Yes.
Probably always start almost 5 millimeter away from the lesion. So that's the catheter is in position. The wire is in reasonably good position. We have reasonably good blood pressure, and we are starting with atherectomy. So prior to that, what we do is we need to press the brake. Can you see that? I'm pressing the brake. So then the brake is on. The wire is not moving now. Then next, open the knob so that you are in ready position. And now start off with burring.
You see, the sound is how it is dampening. This you have to appreciate.
We have Brady. Get the temporary pacemaker. Get the temporary pacemaker. Okay. Yeah. Give one atropine also. Okay, no need of atropine, but we'll have the temporary pacemaker.
Yes.
So at the end of 25 second burring, we'll always wait for another 25 seconds. 25 seconds of burring followed by 25 seconds of waiting.
Yes.
So usually what we do is we wait for almost a minute or so before we start off with the next round. Show the temporary pacemaker wire. That's it. Yeah, the wire is inside a vessel, inside a branch, but then we are not pushing it forward and backward. Let it remain there. Not going to trouble that, right?
Yes. Already you did the brake, na? So wire won't move.
as Dr. Kaparthi had mentioned initially, you'll be more happy doing this case with a Judkins catheter, but then at the end of the procedure, tracking the stent might be difficult. So that's the the spacing, right? Check the pace. Okay, I'll just push it in. Come to AP view. Come to AP view. Show the pacemaker wire. Okay. Okay. Now do the okay. Keep it at 100. Okay. Pacemaker on. 5 output. Change over to another one. Switch over to another one. Get another one. Not the lead, the generator. Dr. Kaparthi, your experience with the temporary pacemaker while doing
No,
orbital?
I will do for everything TPA, especially long segment lesions of atherectomy.
Okay.
So we are doing TPA for a dominant RCA as well as LADs also, proximal LADs.
Okay. All dominant RCAs.
All dominant RCAs.
Yeah, during the last IPCA, we heard from Dr. Siad Ali that they, over the last 1,000 cases or so, they've never had a 100, keep it 100. They never had a temporary pacemaker wire, not even aminophilin they give. But I think it's a bit hard to believe those things.
Exactly. Our experiences are our teachers.
Yes. Can you switch it on? 100, pace it 100. No, it's not pacing. Get another New York lead. Disconnect this. How much of midazolam and fentanyl? How much? 1.5 midazolam and 50 fentanyl. Probably we can give 0.5 midazolam also.
Actually, Deepak, you can park the burr near the lesion only. You can park actually.
Yeah.
Because of Brady, we pulled.
Yeah, we pulled it up and it's somewhere close to the catheter.
Because of Brady.
Because we thought that once we start the burring, we'll move forward.
Sure.
Okay, show the temporary pacemaker wire from the groin. Okay, connect it. Okay, now reduce it, keep it at, okay, reduce it at, keep it at 40, 40. Yes. Okay. You're ready with that? Okay. Join that. Okay. So now again come back to LAO view. Okay. Monitor down. Monitor close to us. Okay. Proper mag. Okay. Okay. So we are going for the next run.
You see damping sound.
Yeah.
And now it crossed. You see how it crossed? Unlike a rota, it is a maximum jump. It is a very, very little jump. Little. Very, very little. If you carefully see.
Again we have bradycardia.
Yeah.
Keep it at 60. Timer on. We would prefer to wait for another 1 minute before we do the next run.
Because of bradycardia, you are pulling the burr back and keeping it.
Yes, closer to the guide catheter.
To be frank, not necessary. Because of our previous rota habits, we will do like that. To be frank. Because initially we have similar type of conditioned reflexes.
In between, you want to check some flow there, like that? Or
You can have.
because
you can
of
have. Unlike
creatinine, you are
yes.
No, not because of creatine. Not because of creatine. It's again, as he told, it's like rota habit. Because every time doing rota, you check in between, you ultimately end up having air embolism inside the coronary. So unless it's really warranted, because even if you have slow flow, you're anyway you have to manage it. So you have to do the burring till the end. Now, if the heart rate doesn't improve, probably we'll do a check and see what exactly is happening, whether the flow is not good. Keep the rate, again bring down the rate to around 40, temporary pacemaker rate to 40, yeah. Shall we give one atropine? No. Every time I speak about atropine, the P wave comes back. So be ready with atropine. Now the rate is around, we have kept the temporary pacemaker at 40. The P waves are not seen. Now we are in sinus rhythm. Now during the procedure, if we doing rotablation, if the blood pressure drops during brady and temporary pacemaker, then we would always give atropine. We would want to have an atrial kick also. But here the blood pressure is 160 even when it's pacing. So we haven't given atropine. So now we have waited almost for 2 minutes. Shall we give one ampule of atropine? Now we have waited for enough of time, almost 2.5 minutes, since we did the last burring. Okay, so we go for the third round. You're ready? Are you ready?
You see how the damping sound you can
Wire is
appreciate.
inside the RV branch. Oh, I didn't know. Oh, wire is inside. I thought it's inside a small vessel distally. Okay, so we shouldn't move forward. We are inside the RV branch, not inside the. Okay, now I think we should take a small shoot. Okay, wire is inside the RV branch. It's inside the RV branch. But then initially it went inside before we exchanged it. It went in there, right?
Yeah, it seems like that.
Yeah.
Deepak.
I think we have done enough of sanding. I think we'll do it once again, Vishnu, with the wire there. Then we're not going too much into the RV branch. Just at the lesion, we'll do it once again. Then wire with the Versaturn wire. Get the Versaturn wire, and then we'll do the imaging. Once we are done with it, we'll do one more burring. Okay.
Yeah.
Flow is good. Okay, we'll do once again. So not going deep into the, not going into the RV, just the lesion alone. Okay, we'll do it. See.
I think your nosicone went, but your butt did
Yeah,
not go.
the crown didn't go into the RV branch.
That's the advantage because of the distance.
അങ്ങനെ ബുദ്ധിമുട്ട് എന്തെങ്കിലും ഉണ്ടോ? തീരാറായി. ചെറിയ വിഷമം. 10 മിനിറ്റിൽ തീരും. Now get ready with the next wire. Okay, now we'll take this out from the coronary. Yeah. Just the guide here. Okay, now what we could do is, can you focus over here? We can move on to a mode known as the glide assist mode.
Yes.
While getting the burr inside as well as taking the burr outside, you can hold on to the button for around few minutes.
Yes. So that is same dyna mode like Rota.
Yeah.
This is a glide assist mode. It's called.
This is
low RPM 30,000 or 40,000 RPM.
Release the brake and then again switch it on. Keep pushing the wire inside and take the burr outside.
It will come out.
Next wire, Anisha. Wire inside. Okay, it's come out. It's come. Okay, now we'll take this out. Now the wire. Give some nitro also. After nitro, we'll do an imaging. Introducer. Okay, now we'll do the OCT pullback. Get ready with the OCT catheter. 20 cc syringe. Anisha 20.
No OCT has to cross, indicating ablation. But very peculiar in case of
Yes.
severe bends, in spite of calcium modification,
Flush
the
the
bend
first
will
ticket.
offer the resistance, especially when
No,
sleeping
not
patterns
necessary.
like those. Calcific bend issues, like non-bend yields, weight devices.
Okay, we are ready. Yes, live view. Enlarge the OCT. Okay. Okay, yes. We haven't given nitro, alle? 1 second, we hold on. We'll give some nitro also. Yes, you are seeing the image there. Okay, that's good. The saline. The saline. Saline. Okay. We're ready.
Cross.
2.75 balloon.
So that is a very classical gutter-shaped concavities caused by the orbital atherectomy. You can appreciate.
7.5. Yes. So now the information that we have got from these images, that is actually distal to the, we are actually distal to the lesion there now. So here this looks like a reasonably good landing zone. Here the vessel size is almost 2.75. The vessel size is almost 2.75. Then as we come more proximally, more proximally, here what we are seeing is probably this is some white thrombus, and you also have some intimal disruption over there. So many times following the orbital, we see these sort of intimal disruption over there, and this could, Dr. Siad Ali feels that this is never a white thrombus. This is all intimal disruption following orbital. But then it looks that at least at these areas, it is more of some white thrombus over there. Now, as we come more proximally, here we do see a nodular calcium over here. This is more of eccentric and nodular calcium over there. And then as we come more proximally, here you can see that this particular calcium, this is all you could see that it's all polished out over here. That's the effect of orbital atherectomy. That's again, as we come more proximally, we see some small white thrombus over there. And again, here you could see that this imaging catheter is close to this particular calcium, probably those areas. Again, you can see that there is some amount of polishing over there. So this is what we typically see. At 12 o'clock position, you can see some polishing has happened. Now at 12 o'clock, 1 o'clock position, you can see that significant amount of sanding has happened. As we come more proximally, here again, you can see that these areas at 11 o'clock, 12 o'clock position, sanding has been done. And as we come further more proximally, the whatever nodule that we saw initially, it's sitting over there. Okay, now we come back to the guide catheter. Now, so we made out that there is some amount of sanding that has been done with this particular device, and now we'll choose the length of the stent. Now that is where probably a 38 would be reasonable. Probably this would be a reasonable distal landing zone. Here this would be a reasonable distal landing zone, and here this is proximal landing zone. Distally it is 2.75. Proximally it looks much bigger. It's almost 4 millimeter. More as we come proximally, it's more almost 4 millimeter. So probably we'll go with a 2.75 into 38 stent. 2.75 into 38. Huh?
So do you feel that there is enough adequate lesion preparation in the midpoint of the lesion? Do we need some more lesion preparation at that, because there seems some concentric calcium over there?
Certainly you need to do some ablation in New York balloon. New York balloon. We'll take in New York. Did it go across? Balloon has been done. Show us that.
Deepak, you have to spend more time with orbital atherectomy.
Pardon me?
You have to spend more time with orbital atherectomy. But anyway, you are weakening with the
Show the
balloon.
balloon
Actually.
dilatation.
If it is
We'll take a
at the
shorter
lesion
balloon.
site,
Short New York one.
any dark boning effect is there?
We were not able to dilate that particular area where we saw that concentric calcium.
Okay,
So
okay.
we'll go with another short balloon. What pressures did we go? 14. Okay, give us another balloon. A short 10. 2.75 into 8. Okay, 2.75 into 8 or 10. NC track, yeah.
Where the maximum concentric thickness is there. Calcium.
Just me. Urina. Okay. Okay. So as somebody was asking there, are you happy with the whatever you have done? Now you could always go in for it's again proved with bench testing, that as here we saw that we just did 3 or 4 times of burring, but as you keep increasing it to up to 10 times, you get more and more of luminal gain. That is what the data says. That's what the bench study says. That's what the bench study says. Well, here we just did 4 times because there was some brady. That was the reason why we had to stop there, and we also felt that the wire was we are not sure how the wire went into the RV branch initially. It was right from the beginning. It was inside the RV branch only. Okay, so it was inside the RV branch. So we didn't want to continue. We didn't want to continue with that. So 4 runs has been done. Some amount of sanding has been done. Always any calcified lesion, you always have to have both these strategies. You need to have an ablative strategy. You need to also have 14, 16, 18. Okay. You need to have a balloon based strategy, and you also have to have a ablative strategy. When you think of an ablative strategy, it is always either rota or orbital, and at times laser in uncrossable lesions, but and followed by a balloon based strategy. A balloon based strategy, again, it depends on whatever see post ablation, whatever you see on the OCT. Based on that, you could decide on whatever balloon based strategy. In a good center, probably they would always go in for seeing this some amount of calcification, concentric thing. They would prefer going in for a they would prefer going in with a IVL balloon. But here we would always want to, being workshop, they are not very affordable. We would also want to keep the cost down. We thought we'd try with a non-compliant balloon. If it doesn't work, think about other OPN options, things like that. So here, this is what we are trying. Did we open it up well at that particular area? It opened up well, right? Okay. Now also keep a guide extension catheter ready. The lesion is open. We'll take a small shoot and then go in with the stent. You want to have one more OCT run? Okay, the pressures are good. We felt that the lesion is well dilated. And would you want to see another OCT run? We'll do an OCT run at least for learning sake. Are you ready with the OCT catheter? Vishnu, the area where we are not able to open it up well, Now with the second balloon, with an 8 millimeter balloon, we were able to open it up. At 16 or 18 atmospheres.
You had open balloon.
We have kept it ready. We
Okay,
didn't
okay.
take an open balloon. It's just a non-compliant balloon. That's an NC truck. We went up to 18 atmospheres. We were able to open it up well.
Okay, okay.
We'll see an OCT run and go with a stent because the lesion has opened up. We'll go with a stent and also a guide extension catheter. എന്നാങ്ങളെ തീരാറായി 2 മിനിറ്റും കൂടെ 5 മിനിറ്റും കൂടെ. Okay, give us a 3 balloon, 312 or so. Three 10 12 New York. Distally it's 2.75. We wouldn't go till there with a 3 balloon. At that area of calcification, we would go with a 3 balloon.
We can see whether dark boning effect present or not.
With the 2.7 initial balloon, which is a longer balloon, almost 15 millimeter long, we had the dog boning. But then with an 8 millimeter balloon, we didn't see any dog boning. It opened up well, but thought of taking a bit more longer 3 millimeter balloon, hoping that we haven't missed any area of predilatation.
Okay, sure.
Contrast. Now we dilate. 10, 12, 14. Negative. 16, 18. 18. Negative. Be ready with the guide extension catheter to 18.
That is the area of friction where maximum calcium is there.
Negative. Again 18. Negative. We will go 1820, 1820, negative, and again 1820, negative. Okay. Before we take out the balloon, it's always good we take a small puff to make sure that there is no perforation there with a 3 mm balloon. Okay, now the aspiration catheter and now the guide extension catheter in New York one. Prior to that, we'll take an OCT run.
I think it seems a lesion preparation there after balloon dilatation, 3 mm.
Are you OCT ready? Just need to മാറ്റിയേക്കോ. Come closer. Give us a New York OCT. Okay, not necessary. Okay, are you ready with the OCT? Okay. Yes. Yeah. Okay, ready? Yes. ശരി കറക്റ്റായിട്ട് ഓൺ ആക്കിയില്ലല്ലോ. Always wait for the OCT catheter, the lens to move back to the original resting position before we pull back the catheter into the guide catheter. Okay, now the guide extension and the stent. I think we have seen enough of cracks there at the area of Vishnu. We'll go with the guide extension and then the yes. നിങ്ങളെ കഴിയാറായി, ഇനി സ്റ്റെൻറ്റും കൂടെ വെച്ചാൽ മതി. 2 മിനിറ്റ്. Okay, now show the OCT images. Another 7.5 glove. So from the distalmost area, now if you look at the vessel in the distal area where you have a reasonable landing zone, here the vessel size is almost 2.9. So certainly we'll go with the 2.75 stent, 2.75 38. And you shall go with this stent. Okay, 2.75 38. Okay, so as we come proximally, you can see some dissection, primarily because the balloon is a 3 millimeter balloon, and as we come more proximally, this balloon has done nothing at this particular area where you have a nodular protrusion over there. Then as we come more proximally, you are seeing areas of cracks. Multiple cracks are seen. You could see that at 3 o'clock position the calcification is much thicker, but at the area of thinner calcium you are seeing cracks with the balloon. So as we come more proximally, again that is the typical thing that we always see. You have thin areas and thick areas of calcification. You will be happy because the balloon would certainly break the calcium at the area where you have thin calcification. But when you have concentric heavy calcification, that is again going to be challenging. With the regular balloon, probably you need to have an OPN or a IVL balloon. Here again you could see that there is a thin area of calcification where the break has been, the fracture has been produced. As we come more proximally, now I personally feel the lesion has been reasonably prepared. Well, here you could see a nodular protrusion over there. Nothing has been done with the help of the orbital atherectomy over there. But this is what we typically see. Following orbital atherectomy, every time you do an OCT, this is what we typically see inside the vessel. You see some dissection, you see here this area, probably you could say that there is actually a hole in the vessel. You can see that this is the vessel. We have reached almost the intima there. With the orbital has actually moved almost into the intima. There is a hole in the vessel. We are fortunate that it hasn't moved out. That's it. So we'll stent. Yeah. Okay. Now highlight. Enlarge the fluoro screen. Yeah, in the intima and media. It's almost reaching the media, right? What you saw there. Okay, we'll go ahead. Vishnu, we'll go ahead. Yeah, we are seeing dissection, and probably this is cut into the media also. The position. Okay, I think we'll go there. Yes.
Good
Not at high pressures. 10, 12. Now we'll get a 3 balloon and a 3.5 balloon for post dilatation. Okay. 10, 12 negative. That's it. 2.75 into 38 Sierra, right? 2.75 38 Sierra. We'll take it out. And did the stent go in without difficulty, or with the guide extension we had to push it with the guidance? It always happens in these sort of difficult lesion. How much ever you prepare the lesion, you would mostly need a guide extension catheter to get the stents across.
No, always in calcific lesions and bend lesions, however they're prepared for delivering long stents, it needs a guide extension catheters in spite of adequate preparation.
Now we'll go with a 2.3 as well as 3.5 balloon. Three. First 3. the 3 into 10, 3 to 10 balloon. Can you ask someone to show the next case also? Next one. Cheryl, huh? Joel, get Cheryl Pothan ready on this. One disadvantage what I felt was with orbital would be with rota, once you're across the lesion, you know that you've done whatever is possible. Then probably you can readjust the wire position and have a more favorable wire bias and have one more run and settle with that. But then with orbital, with the orbital, proximal end of the guide extension. With the orbital, the end point is always difficult. Even though we say that you feel the resistance, you look at the resistance. Okay, you look at the resistance that you feel on your hand, and you look at the pitch of the sound change, the pitch change while doing orbital. All those things are all, it's all very difficult. Most of the situation it's very difficult. As we do more and more of runs, you have more and more of luminal gain. But then there is a compromise between that. As you keep doing more and more, okay, as we come more and more, as we do more and more, you tend to see more and more slow flow. You tend to see more and more white thrombus inside the vessel. So it's basically a trade-off between the luminal gain and the complications that could happen during orbital. So typically, probably at some point of time, you'll have to stop, call it a day and stop, then do the imaging and try with the balloon dilatation. Sir, your comments on that, Kapaji sir.
That balloon is a 3 mm balloon.
It's a 3 millimeter.
3 mm balloon distally, and proximally.
Proximally, we go with a 3.5 because the vessel size is almost 4.
Yeah. Optimization. What you have to do.
After that, 14, 16, 18. 14, 16, 18. Yeah. Okay. Now gives a 3.5 balloon. 8. .5 shot. Most of the time when you do rotablation also, this is what we see. We do not see anything more than this.
Yeah.
This on OCT, that is like you do the rotablation, you see these sort of areas wherein you have some polishing being. I think we take out the wire and re-engage and then wire it. Otherwise it will be difficult. Okay, so this is what most of the time we would see on OCT even after rotablation. So
yes.
You wouldn't see any wonders happening inside the vessel. You would see some polishing. The nodules might remaining there itself.
Yes.
But ultimately at the end of the day, you'll be able to crack the lesion with the balloon.
Yes.
Most of the time, and you'll be able to track the stent also.
Right. You are correct.
You don't have to regret that you didn't do a rota, you didn't do an orbital. Precious.
At the end, what I came to know is uncrossable become crossable by means of atherectomy, undilatable become dilatable with IVL and OPL. Laser also uncrossable to crossable. That's all. These three, uncrossable to crossable. Undilatable, dilatable is IVL and OPL. That is the end of the story. You have to use synergistic devices. But you have to spend more time with orbital atherectomy. That is you should have a lot of patience.
The next one, we'll have the radial slender sheath, 7 French guide catheter, and then 12, 14, and then we'll also have a temporary sheath, at least 6 sheath in, and probably the temporary wire in the inferior vena cava. The next one is also something similar to this. The next case is also, but then the vessel appears to be a little more larger, I'll show you those images. No, we are into that. I'll come. What is it? We are actually. We are. Okay, there. That's good. That's good. Anisha, go up. Go up 14, 16. Anisha, go up 14, 16. Guide the request. Okay, negative. That's it. OCT catheter. Angle കഴിഞ്ഞു. ആ സ്റ്റെൻറ്റ് വെച്ച് വികസിപ്പിച്ചതിന്റെ വിഷമമാണേ, അത് ഉടൻ മാറിക്കോളും കേട്ടോ. എടുത്ത് കഴിഞ്ഞു. എന്തുവാ? കാൽഷ്യൊക്കെ മാറി. അതുകൊണ്ടാ കുറച്ച് സമയം എടുത്തത്. OCT catheter. After OCT, some nitro.
Once adequate apposition expansion, you can stop the procedure, na, Deepak ji?
Yes.
All right.
There's a small kink in the OCT catheter. There's a small kink over there. We try to push with the wire.
That's why in the calcific lesions, what we are doing for both, both for the OCT catheters and the IVLs, guide extension you have to use, and then we have to withdraw the guide extension. That is another thing actually. We have to protect the catheters by guide extensions. Otherwise, this type of difficulties will face actually. The long stents, long calcific lesions after stenting.
Okay, are you ready?
Friction will be.
Yes. Okay. Yes. Now we'll give some nitro. Did we get the area beyond the okay, we've seen it. The imaging lens has actually crossed the stented segment.
Yeah.
So distally we are seeing that particular area. There is no distal dissection over there. The stent is well opposed distally. The luminal areas are more than 5 over there. So that appears to be good. Here
You have to expand it.
This area we have it 4.35. Here you are seeing that you have a nodule over there.
Yes.
You have a nodule wherein you can see that there has been some sanding over there, and there the stent is well opposed over there. Expansion for 4.35 may not be all that great, and then as we come proximally, again it's 5. Stent is well opposed. Here again 5.2. Anything 5 would be good. Here it is more of some plaque prolapse, some amount of thrombus over there. That's the reason why you are seeing it as 4.6, 4.7. As we come more proximally, it is 5 millimeter, 6, 7 and all. As we come further more proximally,
Yes.
that appears to be good. The proximal and also there is no intimal dissection also. The stent also appears to be opened up. So we just go in this particular area
Yes,
alone with
area
a 3
test
millimeter balloon, go at 22, 24 and then stop.
Yes.
This particular area. We can see the angio code registration, the area where we had
True.
just with a 3 millimeter balloon. That's with a 3 millimeter at high pressures and
Yes.
stop. Final shoot edutho illalo, nitro shoot illa. I think we'll do a balloon dilatation and then do a final shoot. Anisha, the 3 millimeter balloon. And we wouldn't be further more aggressive at that particular area because
Exactly.
it's a nodule over there. You can end up having a perforation over there. So we would
True.
go with a 3 at 22, 24
Yes.
atmospheres and we are done with that.
Yes. Yes.
ഞങ്ങൾ ഇന്നേ ഐസിയുലാക്കി കിടത്തിയേക്കുന്നത് നാളെ റൂമിലേക്ക് ഇറക്കാം മറ്റന്നാൾ വീട്ടിൽ വിടാം ഇപ്പം ഇറക്കാം ഈ നെഞ്ചിലെ ആവശ്യം അല്പം കഴിയുമ്പോൾ അതങ്ങ് മാറിക്കോളും അത് അത്രയും കാൽഷ്യം ആയിരുന്നതുകൊണ്ട് ആ ബുദ്ധിമുട്ട് വന്നത് more proximity അവിടെ there will go 22 24 22 24 negative little more proximally little more proximally 22 24 small test and nitro shoot 22 24 yeah that's enough. Okay, we'll give nitro and final shoot and we'll stop. Nitro കൊടുത്തോ ഗൈഡ് ഇപ്പൊ കൂടെ വലിയ അല്ല പൂർണ്ണമായിട്ട് മാറിയല്ലേ ലെയോക്രൈനിയൻ വയറ് പാർഷ്യലി എടുത്താലോ I think we'll stop with that. Finally, that particular under expanded area, we just went up to 22, 24 atmosphere. Can you, Joel, get the echo machine on and just look at the pericardium also before we shift him out. Show us the bladder. Okay, that looks so. Okay, now just have a look at the pericardium and then we'll stop the procedure.